Alright, so continuing with our discussion on gastrointestinal tract. So what we see over here on the right side is these are your basically your psoas shadows on either side of the spine. Over here, this soft tissue density that you see over here, this is your bladder, and over here ahead that we go, these are your renal outlines. These are your diaphragm, this is your left diaphragm and this is your right diaphragm. So in an erect abdomen, if you were trying to see free gas under the diaphragm, these are your places to look for. Again, over here what has come is your inferior margin of the liver. Apart from this, when the x-ray has been taken in a supine position, it's worth noting whether what is the pattern of the bowel gas shadows. So you might have your colonic gas shadows outlining this area over here as my cursor is pointing, and this would be your sigmoid over here, your rectum, and so on. And most of your small bowel shadows will be somewhere over here in the midline. And another thing is, if you were to try and look for any sort of calcification, predominantly along the kidneys and along the ureters. So this will be your level of the kidneys. This is your left kidney, this is your right kidney, and this would be just close to the psoas shadows or along the transverse processes. This would be your line of the ureter. So that's where you might be finding your calculi. And probably over here, if you see a calcification, you should think about a cystic. You should think about a vesical calculus, or there are all other differential diagnoses for calcifications within the pelvis, which include your phlebolytes or your calcified fibroid or even or a dermoid. So we go ahead. So when we have to perform imaging of the hollow viscus, which would include your esophagus, your stomach, your jejunum, your small bowel, and your large bowel, there are predominantly 2 or 3 investigations. One is your barium studies. When you do only your esophagus, you have the barium swallow. When you're evaluating your esophagus, your stomach, and the duodenum, that is your barium meal. Further, as the barium goes down till the ileocecal junction and the colon, that's where you call a barium meal follow through. And if you're trying to evaluate only the colon and you give a barium enema, that's it's known as a barium enema. So you'll be injecting barium through the rectum, and you'll be taking pictures. You'll be injecting barium through the rectum, and you'll be taking X-rays through that. And another way to evaluate is obviously your CT scan. Your CT scan is going to show you all your mural thickening, any masses around the bowel, which will which might be the cause for obstruction. So we begin with a barium swallow, and in case we have to see a smooth esophageal stricture, this is how it appears. This is over here. This is your normal esophagus, and over here, as we go down, it's forming a smooth stricture over here. And over here, just above the stricture, what you have is your dilatation of the esophagus. So what are the causes of a smooth esophageal stricture? It can be a peptic stricture due to there might be scleroderma, post-corrosive injuries, iatrogenic. That means iatrogenic means post any surgical procedure. Something like a esophagoscopy. Mediastinal masses might give rise to smooth esophageal strictures. I mean, these masses, they press on the esophagus from outside and they give rise to the strictures. A leiomyoma, even an achalasia cardia. So this picture over here on the right side that you see, that is due to achalasia cardia. And even a submucosal spread of a carcinoma can give you the picture of a smooth esophageal stricture. Once again, we go on to the next appearance that you might see is an irregular esophageal stricture. The causes again include, carcinoma, leiomyosarcoma, lymphoma. Reflux esophagitis might give rise to a similar picture, Crohn's disease, radiotherapy, and fundoplication. So over here you have your esophagus, over here you have an irregular short segment stricture over here, and this might be another thing that you see over here is the shouldering. Shouldering is this might raise a suspicion for CA esophagus. This is a case of carcinoma esophagus. Over here you see an irregular stricture over here, narrowing. This is dilatation of the esophagus above the stricture. You see a fluid level over here, so the barium is held up over here. And over here you see a typical irregular narrowing, rat tailing of the lumen, so which is a typical appearance for CA esophagus, and obviously over here you get shouldering as well. Another thing is your hiatus hernia. This is like how we discussed that this would be your diaphragm. This is the diaphragm, and through the esophageal hiatus, the stomach has been pulled up. This is the esophagus, so basically the gastroesophageal junction is lying above the diaphragm. So the hiatus hernia might give rise to symptoms of dyspepsia. What about thickened stomach folds? Now these thickened stomach folds, which can be seen because of gastritis, Zollinger-Ellison syndrome, acute pancreatitis can give reactive thickening of the stomach. Crohn's disease, lymphoma, carcinoma, eosinophilic gastritis, Menetrius disease, and varices. So there's a host of differential diagnosis for thickened stomach folds. Now thickened stomach folds are generally picked up on barium meal studies or a double contrast studies. That means a double contrast studies is when you ask the patient to swallow barium and then you give the patient an effervescent substance, so it produces gas. So that gas, what it does is it coats the barium along the walls of the stomach, and that's how you get a double coating. So what are the causes of gastric dilatation? So any lesion which causes fibrosis of the gastric outlet secondary to ulceration, a malignancy, volvulus, infantile hypertrophic pyloric stenosis. Now this infantile hypertrophic pyloric stenosis gives you maybe 3 or 4 signs which you should remember, because these will be asked to you for your MCQs. So there is a string sign, there's a shoulder sign, there's a beak sign, and there's a double track sign. So I have tried to draw a diagram showing at least the shoulder sign. This is your stomach over here, and this is the shouldering over here, and this is another beak sign which happens. So this is your thickened pylorus causing narrowing of the gastric outlet, and this is your first part of the duodenum. Other causes of gastric dilatation would include a bezoar, a postoperative status, post-vagotomy, anticholinergic, and metabolic conditions like uremia and hypokalemia. Again, duodenum, the common causes would include bands. Frequent causes, these are frequent cause of neonatal obstruction, atresia, web, stenosis, annular pancreas. Now what annular pancreas does is, if suppose this is the lumen of the duodenum, the pancreas grows around it. It's a congenital anomaly. So what it causes narrowing of the duodenal lumen, and that's how it causes obstruction. Superior mesenteric artery syndrome, what it does is the superior mesenteric artery, as it arises from the aorta and goes downwards, it compresses the third part of the duodenum. Paralytic ileus due to pancreatitis, and scleroderma. So, like we discussed, that you have to look for the gas patterns of the large and the small bowel. Now, sometimes this might be quite difficult to see, or you might see the dilated bowel, but it might be difficult for you to figure out that which one is which. So what are the plain radiographic findings of bowel obstruction? One is your gastric dilatation of the bowel, air fluid levels, soft tissue mass, calcification, free gas in the peritoneum, and obliteration of fat planes and the psoas shadow. Free gas in the peritoneum would mean that the bowel has the dilated bowel has led to bowel wall ischemia, and there has been a perforation. or probably, there has been a perforation and because of which there has been ileus. It can be the other way around. So small bowel obstruction is suggested when the diameter of the small bowel lumen is more than 3 centimeters. So over here, what we see is actually this is a dilated large bowel, and this patient had a stricture at the lower part of the descending colon due to carcinoma. Strictures in the small bowel. What are the common causes of strictures in the small bowel? These are adhesions, Crohn's disease, ischemia, tumors, which would be your lymphoma, carcinoma, metastasis, and hernia. When I say stricture, the pathology might be either within the lumen of the bowel, within the wall of the bowel, or it might be an extraluminal mass causing compression of the lumen, like as in hernia. Now, if you look at this picture, this is a small bowel enema. So what has happened over here is there is this one particular area over here beyond which the bowel is slightly prominent or dilated. So over here, this is a short segment stricture. This patient turned out to be a case of tuberculosis. Again, intestinal tuberculosis. This is an ultrasound appearance showing thickened walls of the intestine. Over here, these are the thickened walls, and over here you see mild free fluid in the peritoneum. Lesions of the terminal ileum. This can be the most common differential diagnosis in our country is tuberculosis. So other causes include Crohn's disease, ulcerative colitis, radiation enteritis, Yersinia, actinomycosis, histoplasmosis, lymphoma, or carcinoid. Another patient with a barium meal follow through. This is over here. This is your terminal ileum, and this is where a thin, because of the thickening of the wall, the lumen is narrowed, and what you get is a thin string-like appearance of the lumen. So this is how it looks, and beyond which there is mild widening of the proximal ileal loops. And another patient with intestinal tuberculosis. This is how it appears over here, ileocecal junction. This is the cecum. This is the thickening of the cecal wall. This is your normal. This is your normal appearance of your ileum. But over here, this is what you get is your thickened cecal wall. Now, this is a coronal section of the abdomen CT. So this is how it is. But the oral contrast has seen to go through the thickened cecum. Appendicitis. What are the imaging findings in appendicitis that we look for? While we are doing ultrasound, we look for typically a thickened, dilated. Dilated means something measuring more than 7 mm in size. Tubular, aperistatic and non-compressible tubular structure in the right iliac fossa. So, if you look at it, there are these pretty straight guidelines how to describe an appendix or, what to look for. When you do an appendicolith may be seen on ultrasound, but this can also be seen on X-rays or on CT. Periappendiceal fluid collection or loculated collection. This is pretty well seen on CT and ultrasound. Now this phlegmon formation, enlargement of the adjacent mesenteric lymph nodes, air foci within the vicinity of the appendix, and small bowel obstruction. These are all findings which are much easily detected on CT. However, one should know that in the pediatric age group, one does not usually require CT to make that diagnosis. Ultrasound is an excellent modality to rule that out. Colonic polyps. The cause for colonic polyps, these include adenomatous, hyperplastic, hamartomatous polyps, inflammatory polyps, which would be due to ulcerative colitis, Crohn's disease, infective amoebiasis, or Turcotte syndrome. Colonic polyps are usually seen on either barium enema or on CT. After you give rectal contrast, you might be able to see that. But another way, although less frequently used, is due to a virtual endoscopy. So in this, what we do is we insufflate the colon with air, and then we just do a plain scan, or we do a plain and a post contrast scan, and then we, due to post processing, we will be able to see the lumen of the colon. Again, we have taken these colonic strictures, which will be again neoplastic, which will be carcinoma or lymphoma, inflammatory, ischemia, infective, extrinsic masses. Just like in small bowel, you will have abscesses or endometriosis causing inflammation of the wall of the colon, and that might result in a colonic stricture. Once again, over here you have thickened proximal ascending colon, over here like a string over here, and over here this is another patient who has a polypoidal mass within the bowel wall, and this has resulted in a tight stricture over here, and beyond which there is dilatation of the descending colon, and over here dilatation of the hepatic flexure and the ascending colon. So this is your mass, and this has resulted in the stricture. Megacolon. What are the causes of megacolon? One is again distal obstruction, ileus, pseudo obstruction, purgative abuse, toxic, inflammatory. Toxic megacolon is seen in inflammatory causes, ischemic colitis, or even dysentery. Now, this dysentery either due to amoebiasis or salmonella. This might, you should remember the causes of toxic megacolon, because these may be asked in the exam as an MCQ. So, a megacolon is diagnosed when the colonic caliber is more than 5.5 centimeters. So what, like how we did in chest. So what are you should know what are the appearances of tuberculous peritonitis, or tuberculous infection of the abdomen. So over here we have the tuberculous peritonitis. You have free fluid in the within the peritoneum. There is stranding of the omentum with some enhancement on the post-contrast studies. Again, over here, this is another case. This is where you have your free fluid, this enhancement of the peritoneum. Next is you get thickening of the small bowel wall. Over here, these are your small bowel lumen. This is the normal appearing lumen. There's contrast within it. And over here, this is a thickened wall. Another patient with a similar appearance. This is a thickened small bowel wall over here. This is your free fluid over here. And this is the normal appearing bowel wall. Tuberculous lymphadenopathy. Again, what you will see is you will find necrotic lymph nodes. So over here, this is a necrotic lymph node over here, multiple necrotic retroperitoneal lymph nodes over here. And over here, you also see thickening of the cecum, a part of the spectrum of appearances of tuberculosis of the abdomen. But quite often, it might not be easy to differentiate between, causes. Is it due to a tuberculosis? Is it due to some malignancy? Or is it something else which is involving the abdomen? So the next thing that you do is you do an intervention. So intervention means taking a biopsy. So this image shows that there's a ill-defined peritoneal mass over here, and what we've done is we've gone in, we've taken a needle, and we'll be taking a sample of this mass. So ultimately, what we realize is, it's not just the CT. You can there are different modalities to evaluate the abdomen of this, of which and each modality has its own merits. So barium is for you look for mucosal disorders or motility disorders. Ultrasound can be a good examination to begin with. And then obviously you have the CT. CT will tell you a lot. Now we come to the hepatobiliary system and the pancreas. Now the imaging approach. Ultrasound, if there's a patient with jaundice, or if you're suspecting a liver disease, I think ultrasound should be the primary imaging modality to begin with. So, this will give you the status of the liver. It'll tell you whether it's cirrhotic or not. It'll tell you whether there's a mass or not, whether there is dilatation of the intrahepatic biliary radicals, is there pancreatic mass, are there gallstones, or is there any CVD, any other cause causing CVD obstruction. MDCT, again, it'll tell you neoplasms, infections, inflammation, and liver cirrhosis. It'll tell you everything. And when we look at liver cirrhosis, we're not just trying to look at the liver cirrhosis, we're even trying to see whether there's a mass developing within the cirrhotic liver, because hepatocellular carcinoma is known to develop within a cirrhotic liver. And obviously, we also need to know what is the condition of the portal vein. MRI and MRCP used for neoplasms, liver cirrhosis, and storage disorders. Detailed anatomical evaluation of the biliary tree. So whether there are accessory hepatic ducts, is there a pancreatic divisum in a case of chronic pancreatitis? If you want to know is there a pancreatic divisum, that's what MRCP will tell you. And cholelithiasis, obviously. ERCP or endoscopic retrograde cholangiopancreatography. It is done with the help of a scope. It's more invasive than the MRCP. So what it does, you cannulate the ampulla vator and you inject contrast, and that's when you take your radiographs and you'll get the entire picture of the biliary tree. So one major advantage it has is you can also use it as a therapeutic measure. You can stent it, you can remove the distal calculi, and so on. Or you can even take a biopsy. Scintigraphy, functional imaging, biliary leaks, we've already spoken about that. Percutaneous cholangiography, that is when there's an obstruction in the distal CBD and you want to puncture the bile ducts from the transcutaneous approach. So through the skin you go and you puncture one of the dilated intrahepatic biliary radicals. So it also serves as a measure. Either you want to drain the dilated biliary tree, or you want to evaluate, or you want to stent it, to provide. So either you want to drain the biliary tree, or you want to stent the area of narrowing, which might be due to cholangiocarcinoma. So what are the generalized causes of generalized increased echogenicity of the liver? Again, you have fatty liver, cirrhosis, chronic hepatitis, strong storage disorders, and metastasis. Now, this is your routine liver over here, appearing liver. This is your ultrasound appearance. This is your routine liver. This is your surface. This is your liver surface over here. And look at how smooth it is. Had it been a cirrhotic liver, even this is actually a normal liver, but let me show you, if this would have been a cirrhotic liver, I would have seen a nodular contour over here. And these are obviously your portal tracts, and this is your hepatic veins over here, and so on. Liver abscess, again, a very common finding. Over here, this is a CT axial section of the liver. Over here, there's a hypodense collection, which has ruptured into the perihepatic space. Over here, on ultrasound, you see it as a hypoechoic lesion over here. So these are your abscesses. Liver hydatid cysts. These are two different patients which have, this is an ultrasound appearance and this is a CT appearance of two cysts in two different stages. So if there is any calcification, if there are septae, then you may want to think of a hydatid cyst or any other neoplasm. So what are the cystic lesions of the liver? There's a broad list of differential diagnosis, which would include the hepatic cyst, hamartomas, giant hemangiomas, hydatid cysts, abscesses, embryonal sarcomas, lymphangiomas, biliary cystadenomas, cystic metastasis. Cystic metastasis can be, the differential diagnosis for either ovarian or gastric. You need to know what are the causes of cystic metastasis, because, this will be asked. Again, these are these liver metastases over here. This is CT. These are two different patients. So what you would typically see is a bullseye appearance over here, different appearing over here. Over here, it is hypodense in the center, and at the periphery, it shows, it's slightly more dense. So these are your typical bullseye appearance. So what are the lesions having a bullseye appearance within the liver? You have candidiasis, metastasis, lymphoma, sarcoidosis, septic emboli, opportunistic infections, and Kaposi's sarcoma. Liver cirrhosis. Ultrasound can be used to evaluate the portal vein to look at is there an obstruction or not, is there hepatofugal flow or not. So this is evaluation of the portal vein showing flow within the vein. Gallbladder. Again, when we are evaluating gallbladder, ultrasound should be performed, should be the initial modality of choice, because it's an excellent investigation to pick up gallstones. In fact, it has a very high sensitivity, and these gallstones will be easily missed on CT. So this is a case of CA gallbladder. So over here, this mass is over here, it is infiltrating into the liver parenchyma. This is an axial section, this is a coronal section over here, this is the gallbladder mass centered around over here, and it is infiltrating into the liver. Same thing over here on the axial, on the sagittal section. Again, like I said in the beginning, this is a intrahepatic cholangiography. So this is a gallbladder mass showing involvement of the CBD, and then there is resultant dilatation of the proximal biliary tree and the intrahepatic biliary radicals. So what we've done is, they've, through the skin, they've punctured the dilated biliary system, and you try to drain that, and you try and put a stent over here so that the biliary tree drains. Suppose if you're unable to put the stent, what you do is you leave the tube over here in situ, so that there's a drainage, the patient does not have an increase in the bilirubin. Again, MRCP, that is the magnetic resonance cholangiopancreatogram. What it does is, it's a non-invasive method. It shows an excellent details about the pancreatic duct, the CBD, the gallbladder, and the intrahepatic biliary radicals. If there are any anatomical variants, you will be able to pick those up. Now in this picture, what we are seeing is, this is a dilated CBD over here. The pancreatic duct is normal, and there is dilatation of the intrahepatic biliary radicals. Now there are these filling defects over here. These are the dark defects. These are basically calculi within the CBD. So this has resulted in obstruction of the bile ducts and with back pressure changes.